Exercise Theory, Chapter 3, Anatomy. This is Part B. I strongly, strongly encourage you to make sure that you are very, very comfortable with the different bones in the body, with the different planes of movement of the body, with the different movements of the body. So you should know what shoulder flexion and shoulder extension look like, shoulder abduction and shoulder adduction. Because now we are going to carry on and we are going to be talking about the different muscles in the body and how they move joints. And for you to be able to appreciate how they move joints, you need to be very familiar with what the joint movements are. So if you haven't had a chance to look at the textbook, to look at the study guide, please review that now. This will make this portion of anatomy make a lot more sense. So muscles. Muscles are actually bundles of muscle fibers which will run the length of the muscles. These bundles are wrapped in a connective tissue. This connective tissue is called the perimyosin. And within each muscle fiber are tiny cylindrical myofibrils and still thinner protein filaments, which are actin and myosin. Muscle contraction or shortening occurs when a series of biochemical reactions cause the actin and myosin filaments to slide past each other. This is like interlacing your fingers. This method of muscle contraction is known as the sliding filament theory. I encourage you to look for diagrams of actin and myosin. So what happens when we look at the muscle, when we get down to the microscopic levels, we will see that there are microfilaments called actin and myosin. And these two proteins will cross one another and they will pull each of the ends of the muscles closer to each other. So muscle really contracts almost like an accordion folds. So when the muscle shortens, it's because actin and myosin are pulling against each other. And more specifically, the myosin pulls the actin filament, and it shortens a distance between the two ends of the muscle. So a shortening muscle will pull the two ends closer together, so the two tendons on either end will get closer together. And as a result, when the muscle shortens, it will pull on the bones that it's attached to. When we talk about movements that the muscle creates, that a muscle will create, all will happen is that muscle will shorten and the movements it causes will simply be related to what it attaches to. For example, your biceps, we'll see shortly, are going to attach to your forearm. And so when your bicep shortens, it contracts, it will pull the front part of your forearm closer to your humerus. And as a result, you do an arm curl movement. So when you think about movements that a muscle causes, you need to know whether or not the muscle will cross the joint. So we can only act on joints which it crosses. And what happens to the muscle when the muscle shortens or does what we'll see is called a concentric muscle action. So here's just a visual about what we just talked about. You can see the muscles in this gentleman's forearm. So it goes from his tendon into his muscle. And then the muscle is going to be bundled with an epimyosin. It's going to end up having perimyosins and then a bundle of muscle fibers into the individual muscle fiber itself. When you take a picture or take a look at that picture of the skeletal muscle fiber cell, when that muscle contracts, just think about that last segment getting shorter in length. And when it gets shorter in length, the muscle will pull on the tendons, and the more movable bony attachment will be pulled closer. So just pointing out here, there's different types of cells in our bodies. Okay, there's blood cells, skin cells, goblet cells, bone cells. And then we have three different types of muscle cells. We have cardiac muscle cells, smooth muscle cells, and then skeletal muscle cells. Skeletal muscle cells are very unique, so our muscles are unique. They are excited by the central nervous system, and when they are excited, they will contract and shorten. So once again, if you picture those tubes that you're looking right there, the skeletal muscle cells, when they contract and shorten, they would get shorter in length, almost like the reverse of what a slinky would do. So imagine the muscle cells like a slightly stretched out slinky, and when it contracts, it gets more compact. It shortens in length. So muscles can be affixed to a bone in different ways. They can be a fleshy attachment. So this is where that muscle fiber, so when you look at diagrams, the muscle fiber is the red or reddish pink color. They are directly attached to the bone. This direct attachment, a fleshy attachment, will usually occur at the attachment that's closest to the torso, okay, so the core part of the body. These type of muscles will cover a wide area, so the force is distributed rather than localized. Examples of muscles with fleshy attachments would be our gluteus maximus and our trapezius. The second type of attachment is going to be a fibrous attachment with tendons. So once again, when you're looking at diagrams, the muscle will be red or reddish pink. The tendons go white. So you'll notice that goes muscle into that tendon that would be white attaching to the bone. So this tendon is going to be continuous. So the tendon is attached to the muscle and then attached to the bone, right? And it's going to be attached with multiple fibers going into the bone. It makes it a very strong attachment. So the muscle itself will shorten. It will pull on the tendon, which in turn will pull the bone. So here we have a diagram. You'll also have this in your textbook. This is going to show us the major muscle groups that we need to be familiar with and we need to know. So let's start with the diagram on the left. I'm going to introduce you to all these different muscles, and then we'll go through and talk about them individually with written down what their attachments are. I remind you, like I did on the last slide, that this is a new language that you're now using if you haven't been exposed to it before. It will take time, practice, and repetition to become comfortable with these. So I remember this stuff from simple memorization. You have to go over it over and over and over again, and like learning any new language, with repetition, it will become easier. So our pectoralis major, they're starting on the left, that is going to be our pecs. You'll often hear it called our pec muscles. This is going to go from our anterior chest, and it attaches to our humerus. So our pectoralis major, we'll soon see, will move our humerus. It will be able to cause shoulder flexion, horizontal adduction or horizontal flexion, as well as adduction. It's a very powerful muscle. We work this muscle when we do bench press, when we do chest press or chest flies, and we also work it with a push-up. It works by moving the humerus. The next one is our biceps brachii. The biceps will actually attach to the scapula, and it will go down and attach to our ulna. The biceps will cause elbow flexion. Because they cross the shoulder as well, so it attaches to the scapula, and it crosses the joint at the humerus, it will also assist a little bit in shoulder flexion. So it'll assist a little bit in shoulder flexion. The next one they have down are the rectus abdominis. So this is in the midline of the body. This is your 6 or 8 pack muscle, your abdominal muscle. This is the muscle that we exercise when we do ab curls. This is the one that everyone's looking for, those washboard abs. They're talking about your rectus abdominis. Deep to the rectus abdominis is the iliopsoas. It's often called just the psoas. It's a combination of two muscles, the iliacus and the psoas. And we use the layman's term for this, and you cannot see it in this drawing. It's underneath everything. We'll have a better picture of it for you. But this iliopsoas is the hip flexor muscle. Its job will be to flex the hip. Going down into the leg, you'll see the quadricep muscle. The quadriceps are named the quadriceps because it's a grouping of 4 muscles. These 4 muscles will start either on the pelvis or on the femur, and they'll all blend together to a common quadricep tendon, and that's where you find the patella or the kneecap. Once it crosses the kneecap, it will become the patellar ligament and will attach onto your tibia, your shin bone. One of the quadricep muscles will cross 2 joints. It'll cross the hip joint and the knee joint, so it will be able to cause hip flexion and knee extension. That muscle is the rectus femoris. Rectus femoris will cause hip flexion and knee extension. The other 3 quadricep muscles are the vastus medialis, which attaches medially and is found medially on the femur, the vastus lateralis, which is found laterally on the quadricep, and then the vastus intermedius, which is deep to the rectus femoris. These muscles all will start on the femur and will go to form, along with that rectus femoris, the quadriceps tendon into the patellar ligament. These muscles of the quadricep, vastus medialis, vastus lateralis, and vastus intermedius, only cross the knee joint. And when they shorten, they will pull the attachment that goes to the tibia. They'll pull on that attachment, and they will extend the knee. The tibialis anterior is going to start on the tibia. That's where it gets its name, tibialis anterior. It's attached to the anterior part of the tibia, and it will go down into the foot joint. When this muscle contracts, it will dorsiflex the ankle, so it will bring the ankle up. Then you have, so carrying on with the picture, we would have the gastrocnemius and soleus. These 2 muscles are found at the back of the leg. These are our calf muscles. The gastrocnemius is easier to see because it's superficial to the soleus. This is our calf muscle. The gastrocnemius will cross the knee joint and the ankle joint. So the gastrocnemius will cause plantar flexion, but it will also assist in knee flexion. The soleus only crosses the ankle joint. Because it only crosses the ankle joint, it can only act on the ankle joint. So when this one contracts, it will cause plantar flexion of the ankle. The gastrocnemius and the soleus will come together to form the calcaneal tendon. Calcaneal tendon is also known as your Achilles tendon. Your sartorius is a muscle that's going to go from the pelvis to the medial knee. When this muscle contracts, it will flex the hip, flex the knee, and externally or laterally rotate the hip. We will be talking about a group of the hip adductors. These muscles will adduct the hip. They will take the hip from a widened position, so an abducted position, and pull it back to the midline. Working up the picture, we will have the internal and external obliques. We can see the external obliques, we cannot see the internal, but these are abdominal muscles that are going to be they're used to do lateral flexion and rotation of the spine. The transverse abdominis, we'll discuss shortly, is deep to all these muscles. We can't see it in this diagram, and it works as a corset. Into the shoulder now, we have our deltoid. The deltoid has 3 different parts, and we divide up these 3 different parts because they do have different roles. The deltoid functions and sits almost like a shoulder pad on your shoulder. The anterior fibers are in the front, the middle fibers are in the middle, and the posterior fibers are found around the back. These will arise from the clavicle and the scapula, and they all attach to the humerus. Your anterior deltoid will allow movements to happen in the front. So this muscle will help do horizontal adduction as well as flexion of the shoulder. The middle deltoid will allow you to do it will allow you to do abduction, regular abduction. In fact, this is the major muscle that will do shoulder abduction, the middle deltoid. The posterior deltoid, the back of the shoulder, will help with doing shoulder extension as well as horizontal abduction. Now we're looking at the back of the body here. We have the trapezius. Trapezius kind of confuses people a little bit too because there's three different portions we'll be talking about: an upper, middle, and lower portions. It's important to note here that a muscle fiber can simply shorten and compress itself. So if you look carefully at the lines that are drawn of the muscle, the trapezius, you'll see that those fibers are drawn in different directions. So your upper trapezius will cause the scapula to elevate. Those fibers will go between the neck and the scapula, and when they shorten, they will lift the scapula up. The middle fibers, which would be located around the area where it shows the rhomboids area, would do the same thing that the rhomboids do, and they will retract. They will retract the scapula, so pull the scapula closer to the spine, making the shoulder blades squeeze in the back. The rhomboids are deep to the trapezius, so we can't see them in this diagram, but they'll do the same thing as the middle trapezius. And then finally, the lower trapezius, the fibers that are going down, you'll see those run from the scapula to the mid to lower spine. If you look at the direction those work in, you will see that their role is to depress the scapula. They will pull the scapula down. The trapezius do not attach to the humerus, so they cannot move the arm. They attach between the spine and the scapula. So their role, the trapezius role, will be to move the scapula. And it will either elevate, retract, or depress the scapula, depending on which fibers are contracting. Next, we have the triceps. The triceps are shown on the back of the arm. They will go from the scapula down to the ulna. And this muscle, the triceps, will primarily extend the elbow, but it'll also help to extend the arm because it's going to cross the joint between the scapula and the humerus. The Latissimus dorsi, this is that big, powerful swimmer's muscle. It starts off in the low back. It comes up to the front of the humerus. So it scoots under the armpit to attach to the front of the humerus. As such, the Latissimus dorsi is a powerful shoulder extender, a powerful adductor of the shoulder, a powerful adductor, as well as a strong medial rotator of the humerus. The erector spinae are located underneath the fascia in the low back. The erector spinae goes straight up and down the spine. That's where it gets its name, with erector spinae. And its job is going to be to extend the spine. The gluteus, medius, and minimus, you can't see the minimus, it's under the medius. These are our glutes, the medius and minimus. They lay more on the outside posterior part of the hip. And they are going to be in charge of hip abduction. Hip abduction. The gluteus maximus, I always think of this one as a skater's muscle. The gluteus maximus is going to be very powerful at hip extension and external rotation. Gluteus maximus will do extension and external rotation. And finally, we have the hamstrings. This is the back of the thigh. From left to right on this diagram, you are going to have the yeah, sorry about that. There seems to be an error. So let's just start. Yeah, they kind of blended them together here. There are two that are on the medial part of the thigh are the semimembranosus and semitendinosus. These are going to arise in the pelvis and attach in the medial tibia. Pelvis to medial tibia. And it's the semimembranosus and the semitendinosus. The biceps femoris, which was listed twice. Yeah, this is not completely accurate, this picture. Biceps femoris starts also in the pelvis, but will go down to the fibula and will attach to the lateral leg. Because the hamstrings will cross the hip joint and the knee joint, the hamstrings will be in charge of hip extension and knee flexion. So this provides you with an overview. Do not worry if this was overwhelming. We're going to talk about each one of these muscles individually. We are going to be starting off with the abdominals. So right up front, you can see that lovely rectus abdominis. Rectus abdominis. So this is the 6 or 8 pack muscles. They have tendinous inscriptions or insertions in between them. This is going to give it a biomechanical advantage, this muscle. When this muscle contracts, so take a look at this drawing. When this muscle contracts, it is going to take the rib cage, which it attaches to superiorly, and it will pull it down towards a pubic bone, which it attaches to inferiorly. That's the rectus abdominis. On the sides are the external and internal obliques. The external are just that, they're external. If you were to take your hands on an angle like you're going to put them in your pockets, your fingers would point in the direction that the fibers run for your external oblique. So they go down from the upper outside to the lower down on the medial aspect. Okay, lateral, superior, medial, inferior. The internal obliques run the opposite way. The internal and external obliques will work together to allow lateral bending and rotation of the spine. The innermost layer are your transverse abdominis. This is going to act like a corset around the spine. It actually will not move the spine. Instead, if you were to suck your abdominals in hard, that would be contracting your transverse abdominis. It's going to work as a sling, as a corset, and be used for spinal stability and stiffening of the core body. It will not cause movement of the spine, so it will not cause flexion or extension. Other things that are pointed out here are the linea alba. That just means white line, and that is the space in the center where everything attaches in the front. You see on the right that there is a cross section of the abdominals. And in that cross section, it'll show if they were to cut you in half, how you have that rectus abdominis, the external obliques, the internal obliques, and innermost, the transverse abdominis. Let's talk about these individually. I caution you not to get too worried when you see the list of all these attachments, okay? I want you just to follow some general rules, okay? Transverse abdominis, it's the inner lip of the iliac crest, so that's part of the pelvic bone. The thoracolumbar fascia, which is just connective tissue in our low back, as well as the lower 6 ribs. That's where it starts from in the back. And in the front, it attaches to that fascia of the linea alba. All you need to understand is that the transverse abdominis starts in the low back. It's attached to fascia in the low back, and it loops around to attach to fascia in the front, the linea alba. When this muscle contracts, it will constrict the abdominal contents. Okay? It works like a ring or a corset. It will not cause spinal movement. Okay? The rectus abdominis is going to run from the pubic crest, so that is the front of the pelvic bone, the pubic crest, to the xiphoid process in the costal cartilages of ribs 5 to 7. So it's going to go from the pubic bone up until the medial part of the rib cage. The xiphoid process is right at the very bottom of the sternum. It goes to those 2 points. So when it contracts, it will pull those 2 parts closer together. So it will pull the rib cage closer to the pubic bone. So therefore, it will flex the trunk. Now, if you only have one side contract and not the other, so if you only contract one side, it'll also help with some lateral flexion. Your external obliques will attach to the rib from the ribs at the back to the linea alba at the front. Okay. The internal obliques, so like I said, they run the opposite direction. So in the back, they'll attach to your iliac crest, which is part of your pelvic girdle, and they'll come to the front and they'll fan out. So some of them will attach to the pubic crest, but the rest will attach to the linea alba or inferior ribs. What the obliques will do is when one side contracts, of both the external and internal obliques on one side, all of those contract, they will cause lateral flexion to that same side. When the external obliques on one side contract and the internal obliques on the other side contract, they will cause rotation of the spine. These muscles will also, if they all contract together, they will also assist with flexion of the spine. One other thing that they'll play, and it does talk about the external obliques pulling down the chest, but a lot of it is actually the internal obliques. They really will help to stabilize the chest and the thoracic cage. So they will help with forced expiration, they'll compress that abdominal cavity, they'll help to pull the rib cage down. And here it is one more time, that rectus abdominis, the obliques, and the transverse abdominis. Please understand where things are located, but don't get too hung up on details. No one's going to ask you if it was ribs 9 to 12 or 10 to 12. No one's going to ask you specifics like that. So just have a general idea of where they are and understand that what that muscle will do when it shortens, what bones it will pull. So muscles of the upper arm. Okay. And actually, I apologize. I misspoke. I'm sorry. I just realized I misspoke. I was talking about the biceps being attached to the ulna. They're not. They're attached to the radius. I said that in that first slide. So they are attached to the radius, not the ulna. I think I misspoke that. I apologize. So our biceps actually has 2 heads. That's where it gets the term biceps, 2 heads. There is a long head and a short head. Both of these heads will attach to different parts of the scapula. The long head will attach to the scapula just above the glenohumeral joint, so just above where the humerus goes in. And then the short head will attach to the coracoid process of the scapula. So it's this beak-like process that we have that comes forward. So both of the biceps will attach to the scapula and they insert onto the radius. Once again, I misspoke that. They insert onto the radius, not the ulna. Whenever the biceps contracts, it will flex the arm, so it causes elbow flexion. But where it attaches on the radius will actually cause that forearm to supinate at the same time. So the place that it's attached to will cause supination as flexion occurs. And because they have the same insertion, they will cause that same action at the elbow. Because they do cross the shoulder joint, they will assist with shoulder flexion. They will assist with shoulder flexion. Here we have our deltoid muscles. And I mentioned them already, the anterior, medial, and posterior deltoid. So they all insert onto the humerus. In fact, you could kind of follow that muscle down on yourself and you could feel that insertion point where it goes in towards the humerus. The anterior deltoid will start on the clavicle. The medial deltoid will attach to the acromion process. That is part of your scapula. It's the lateralmost part of your scapula. And the posterior deltoid will attach to the scapula too, but it's a part of the scapula called the spine. If you were to reach over and feel your shoulder blade, you'll feel that bony ridge along it. That's your spine of your scapula. Now remember, a muscle can only shorten its fibers. So if you look at the way the fibers run for each of these different portions of the deltoid, you'd be able to understand what action. So let's look at that red anterior deltoid. So it goes from the humerus to the front of the clavicle. If those muscles shorten, it will cause horizontal flexion of the, or sorry, another way of saying that is horizontal adduction of the humerus if the arm is out to the side. Okay. It's not going to be very strong at abduction of the arm, but it will help the medial deltoid abduct the arm. The other thing that's not listed on here that the anterior deltoid's very good at is shoulder flexion. Anterior deltoid's very good at shoulder flexion. So once again, anterior deltoid will assist with abduction, will help with horizontal flexion, and will do flexion. It will also assist with some medial rotation of that humerus, so it'll roll the humerus internally. The medial deltoid, this is going to go from that lateralmost part of the acromion process. It's a purple one. That acromion process is part of your scapula, and it will insert into the humerus. When this muscle shortens, it will cause abduction of the humerus. It's the strongest one of the three that will do abduction. The other two will assist. The posterior deltoid, that's going to be on the far right, so we're looking at a posterior view. This is going to attach to that bony spine of the scapula. It's not attached to the spine, but to the spine of the scapula. Because of where it's located, it will assist with abduction, but it'll be very, very good at a horizontal extension. Okay, horizontal extension, so it does the opposite movement of the anterior deltoid. It'll also help with general extension of the shoulder. It'll extend the shoulder back and be good at lateral or external rotation, rotating that arm outwards. So the triceps brachii. The triceps are going to have three different heads. That's where it gets its name. The triceps brachii, a lateral head, a long head, and a medial head. Don't worry too much about the exact attachments. You should understand, though, that the long head of the triceps will actually attach to the surface of the scapula. So it's attaching to the shoulder blade. The lateral medial head will attach to the humerus. The lateral head will be the lateral aspect of the humerus, whereas the medial head will be the medial head, or medial surface of the humerus. Because the long head of the triceps will cross the shoulder joint, the long head will assist with extension of the shoulder. The long head of the triceps will assist with extension of the shoulder. All three heads are going to come together to form a common tendon, and they will all attach to the olecranon process of the ulna. The olecranon process of the ulna. Because they're going from either the scapula or the humerus to the ulna, their job as a group will be to extend the elbow. They extend the elbow. When they shorten, the elbow will extend. So once again, the long head will help with shoulder extension. All three will do elbow extension. So just as a reminder, there are three bones that make up the shoulder girdle. That is the clavicle or collarbone, the scapula or the shoulder blade, and the humerus. So it's really the humerus that attaches to the scapula. The humerus will come and create a joint with the scapula, and then the clavicle in the front will kind of work as almost a strut. Okay? So the shoulder girdle, so especially the humerus, will provide the greatest range of motion. And that the movements of the shoulder girdle are dependent on the shoulder joint and its muscles. So once again, the humerus moving in that ball and socket joint. But also some of the movement will come from the sliding movements of the scapula. So remember I mentioned before the scapular movements on the rib cage of elevation, depression, protraction, retraction, and upward rotation. So we're going to talk about some of the muscles that will attach onto that humerus. So the big one is the pectoralis major. The pectoralis major is going to have different fibers running in slightly different directions. And for the generally, it'll attach to the middle half of the clavicle, the medial half. It'll attach to the sternum and some ribs. So it makes a big fan shape. All of those fleshy attachments are going to come to a common tendon to insert on the humerus. This is going to allow this pectoralis major, to do a lot of different movements. So it will flex the shoulder. When the arm is out to the side, it will adduct the arm back. It will do horizontal flexion or horizontal adduction, which would be a chest fly or a pec deck movement. And also because of where the tendon attachment is on the humerus, because of that exact position, it will allow for medial rotation of the humerus. So once again, it will allow for flexion, adduction, horizontal adduction, and medial rotation of the humerus. Once again, picture the fibers of the muscle, and you remember, if they are going to move something, they're going to do it by shortening and contracting. They could simply pull. A muscle can only move a bone by pulling on it. We're going to be looking at some muscles in the back right away, but I wanted to just give you a nice picture of it before we start looking about an individual. There you see the trapezius, and I've already mentioned trapezius confuses a lot of people because it can do so many different actions. But looking at this picture, you can clearly see 3 different orientations of muscle fibers. You can see upper trapezius, which is going to go from your scapula to your upper spine. Your middle trapezius, which is going to run from the scapula to the middle of your spine. And then the lower trapezia, which goes from the scapula to your mid-spine, so the lower part of your mid-spine. So depending on which of these fibers contract, it will cause the scapula to move. Now let's make something very clear. The trapezius does not move the humerus. The trapezius cannot move the humerus because it doesn't attach to it. It attaches to the scapula. So when you hear trapezius, you are thinking shoulder elevation if it's the upper traps, shoulder retraction if it's the middle traps, or shoulder depression. Or other ways of thinking, scapular elevation, scapular retraction, scapular depression. It cannot cause flexion or extension. It doesn't attach to the humerus. Also here you'll see the rhomboids. So the rhomboids are deep to the trapezius. So in this picture, on the left-hand side, you are seeing the superficial muscles of the trapezius and lats. On the right side, they've removed the trapezius, they've moved the latissimus dorsi, and now you're seeing the rhomboids, which are underneath the trapezius, as well as lower down, you're seeing the erector spinae. So here we go, the trapezius. The upper division is going to attach at the skull and the cervical vertebra. It inserts to the lateral third of the clavicle, and its action is elevating the scapula. The next group is the medial trapezius. So this is going from T1 to T5, so the upper part of the thoracic spine now. It attaches to the spine of the scapula, and its main job is going to be to retract the scapula. It will also help with a little bit of elevation depending on which fibers they are. Then you're going to have the lower trapezius. This is going from T6, your mid-thoracic spine, to your lower thoracic spine. It's going to attach also to the spine of the scapula. And because of the way its fibers are oriented, it is going to depress, and it'll also help a bit with retracting the scapula. None of them will move the humerus. They do not attach to it. They could only move the scapula. The rhomboid major is underneath, okay? And we are going to talk about the rhomboid major and minor separately, but please don't get too worried about major and minor. Understand them as the rhomboids. The minor is just above the major, okay? Minor would be smaller. So rhomboid major runs from T2 to T5, so that's your thoracic spine, and it attaches to the medial border of the scapula. And it helps to retract that scapula, and it will also have some rotational components in there too. So there they are again. So see the two rhomboid division? It's that smaller one that's superior is your minor, which we're about to talk about, and major is just below. Please also note we're about to talk now about the rector spinae. So please note that they're running vertically up the spine. So rhomboid minor, which I mentioned, it's a smaller one. It runs from the very bottom of your neck, so bottom of your cervical spine, to the very top of your thoracic spine, to the medial border of the scapula, and it will retract, and because of the angle it's pulling at, it'll also slightly elevate that scapula. Erector spinae, we have greatly simplified erector spinae for you in this course, okay? These are going to be muscles that run the length of the spine. There are multiple levels of them, okay, multiple levels of them. They start down in the pelvis, they go all the way up to the cervical spine. But the main ones that we end up exercising tend to be kind of that mid region. So here they're talking about the grouping that are in the thoracic vertebra. You'll also find them in the lumbar. So no one's going to ask you the exact attachments of your erector spinae, but you should understand that they attach at the vertebra, right? So they'll attach at a lower vertebra and they'll go to a higher up vertebra. And when these ones contract, they extend our spine. Erector spinae, they hold us up erect and they will extend our spine. And there are multiple levels. There's some in the thoracic, some in the lumbar, some in the cervical spine. The last one I'm going to point out, and we're going to be talking about next, is the Latissimus Dorsi. We call this the lats. You'll notice how it's arising from the thoracolumbar fascia. If you look, that's that white part. It's connective tissue. Fascia is a type of connective tissue. It's a very large muscle. It's arising from there. It's arising from the spine as well. And it is going to go up. Please notice how it goes up to the left there. And it's going to go into the armpit. And it attaches to the anterior part of the humerus through the armpit. Okay. So in a very complicated sounding way, it arises from the posterior part of your pelvic bone, posterior crest of the ilium. It's rising from your sacrum. It arises from your lumbar vertebrae and from the lower 6 thoracic vertebrae. And it's arising from there, and they're all going to go up. It's very fibrous attachment, and it's all going to go up into a single tendon that's going to attach on the medial side of the anterior medial humerus. So it will have several different functions. It will adduct the arm. So when my arm is out to the side, it will adduct and bring my arm back to my body. It will extend my arm. So it'll take my arm backwards. And it will also medially rotate my arm. So that means it will turn it medially. So if you bend your elbow, so have your arm, just normal position, bend your elbow. If you medially rotate your humerus, that would be rotating so that your hand would come across your body with your elbow out to the side. If you laterally rotate your humerus, that is where you would take your hand out to the side and the elbow on the inside. So the lats will medially rotate. They will extend, adduct, and medially rotate. let's remember one thing. Let's look at pectoralis major. Pectoralis major will have two movements in common with latissimus dorsi. Both of those muscles, pec major and latissimus dorsi, will both adduct the arm. They will both adduct the arm that's held away from the body. They'll pull it back in. Because of where they are both attached to the humerus, they will both be able to medially rotate the humerus. Their other functions are where they differ. The latissimus dorsi will extend the shoulder, whereas a pec major will flex the shoulder and horizontally adduct as well. So the rotator cuff. Rotator cuffs are small muscles. They start on the scapula and they will insert onto the humerus. These muscles have a major role of initiating little movements, rotational movements, as well as pulling the humerus into its joint. Okay, so it pulls the humerus tight into the glenohumeral joint so that the humerus can move better, more strongly, more powerfully. So the names of them are the Superspinatus, the Infraspinatus, the Subscapularis, teres minor, and teres major. The supraspinatus is located above the spine of the scapula. This is the muscle people usually have a problem with when they end up with rotator cuff tears. They get impingement syndrome. Infraspinatus is the muscle that is underneath. You can see it right in this picture, underneath the spine of the scapula. Subscapularis you cannot see in this picture. Subscapularis is actually a muscle that is anterior to the scapula but posterior to the rib cage. So it attaches to the scapula but on the anterior aspect, so it lies between the scapula and the rib cage, so we can't see it. It too will attach to the humerus. The teres minor is actually the last of the rotator cuff muscles. The teres minor is going to be very similar to the infraspinatus, and we'll see that in just a moment. It'll attach to the scapula to the humerus. The teres major is actually not one of your rotator cuff muscles. It pretty much is like mimics what the lats do, okay? It does the same thing as the latissimus dorsi. So teres minor will act like the infraspinatus. Infraspinatus, pardon me. And teres major will act like the latissimus dorsi. So supraspinatus, it originates at the supraspinous fossa, so that's above the spine of the scapula. It attaches to the top of the humerus. Its job is it will help to abduct the humerus, and it provides stability to the glenohumeral joint, and that's just the joint between the humerus and the scapula. Infraspinatus is in the infraspinous fossa, so it's below the spine of the scapula. It attaches to the top of the humerus, and it will cause lateral rotation of the humerus and provide stability. Let's skip subscapularis for a quick second. Let's go to teres minor. So this is also below the spine of the scapula, but now we're gone so far below that we're now the lateral border of the scapula. It attaches to the top of the humerus, and you notice it does the exact same thing as the infraspinatus. It does lateral rotation. Let's step back to the subscapularis. Subscapularis is on the anterior surface of the scapula, so it's between the scapula and the ribs, so you can't see it in that picture. It also attaches to the top of the humerus, and this one will cause medial rotation. Supraspinatus abducts. Infraspinatus and teres minor will laterally rotate. Subscapularis will medially rotate, The last muscle in this list, which is not a rotator cuff muscle, is a teres major. This is also going to be part of the scapula. It will go from the scapula to the humerus. And remember I told you it's going to mimic the lats. So it's going to do adduction and medial rotation of the humerus. So it'll do the same thing the lats will. Won't be as powerful as the lats, but it'll do the same thing. And there they are again. Okay, so once again, you cannot see subscapularis. Teres minor and infraspinatus will do similar things. Teres major and latissimus dorsi will. Superspinatus will abduct. So let's move into the lower body. We have the glutes. The gluteus minimus we can't see because, as you can tell from these diagrams, the gluteus medius will cover it. Whenever I think of the glute muscles, I will think of gluteus maximus working by itself, and then the two gluteus medius and gluteus minimus as working together. Because you're about to see they're going to do very similar things. Gluteus maximus, picture a skater. Okay? It's going to go from posterior gluteal line of the ilium. So it starts at the pelvic girdle. It will attach to the top of the femur, okay, into the greater trochanter and into the iliotibial band or iliotibial tract. The gluteus maximus extends the hip, and it will externally or laterally rotate the femur. So picture skating. Imagine what it's like when you go to skate, you extend and you externally rotate. That is what the gluteus maximus does. The gluteus minimus and medius, both are going to be on the outer surface or the lateral surface of the ilium. They both will attach to the top of the femur. They will both abduct the femur, so they will take the leg directly out to the side. They will rotate the femur medially. So they'll rotate the femur so the toe points inwards. So if you remember that medius and minimus work together, and if you can remember that gluteus maximus is like a skater, it will extend and externally rotate the hip, then you're going to know minimus and medius are going to do the other direction. They're going to internally rotate or medially rotate the hip. And they will also abduct the femur. So we've mentioned these guys, but you couldn't see them before. So now what you're looking at in this picture are the hip flexor muscles. We will often refer to them as hip flexors. You'll often hear that terminology, hip flexors. It's really two muscles, the iliacus and the psoas muscle. These muscles, what you're looking at in this picture is they've removed the abdominals and they've pulled the guts out of the person. So these muscles will originate in the posterior part of the body. So these will originate behind our guts. Okay, they're attaching to the back of our pelvis, and they're attaching to the back of, or actually the front part of our vertebra. The psoas major will actually arise from the lower 5 vertebrae, the lumbars, and the iliacus will arise from your ilium. And they're going to insert on the lesser trochanter of the femur. So when these guys shorten and contract, they are going to flex the hip. You can see how they're attaching to that femur. So when they shorten, they'll pull on that femur bone to pull them up. So psoas major, it's located at T12 to L5. It inserts onto the femur. It will flex the femur at the hip. If you keep the hip stabilized, right, and you lock the hip into place so that you cannot bring the thigh up, it will in turn take the lumbar vertebra and move them closer to the hip, the leg. So imagine doing a sit-up with your feet locked. And you're not talking about an ab curl. I'm talking about a full sitting up sit-up. When you sit completely, you go from lying down to sitting completely upright. You have locked your feet in place so that you cannot move your femur, and instead the pelvis and the lower lumbar spine are moving closer. That is how you could also work these. The iliacus is going to come from the iliac crest, attaches to the femur, and same thing. If the leg is freely movable, it will flex the femur up, so it'll flex the hip joint. If you fix the leg in place, it will cause flexion of the pelvis towards the leg. And there they are again. So you'll hear it iliacus, iliopsoas, or just simply psoas. So this is just going to point out here too, the pelvic girdle, and I mentioned before that it was multiple bones. It's actually 3 fused bones, okay? So similar to the skull, a little bit different. is it used to be different parts of the bone that all fuse together. The difference is the skull ends up having sutures. This bone fuses solid. So the three fused bones are the ischium, the ilium, and the pubis. The pubis, you think of the pubic bone in the front, that's where the pubis originates. The ischium, you know when you're sitting down and we talk about sitting on your sit bones, or else if you're sitting down now, put your hand underneath your glutes and you'll feel that bony prominence. That is your ischial tuberosities, part of your ischium. And the ilium originated being more like the iliac crest. So these guys, this pelvic girdle, these three fused bones are going to attach to your sacrum. Your sacrum is going to be the base of your axial skeleton. This is going to help your pelvic girdle will help transmit forces from the upper body to the lower body and vice versa. It will also protect your internal organs. Okay, and it's specifically the ischium part of that pelvic girdle that's called the sit bones. So when you put your hands on your hips, you're actually feeling your iliac crest, your ilium part. The pubic bone you could feel in the front, and then the ischium in the back. So those three all came together, they fused. Technically they're called the innominate bone when all three fuse, which actually means no name. It's an odd shape. So now we're going to talk about the lower extremity and how this attachments from this pelvic girdle are going to make a difference. So here you have your ischial tuberosity. So what we're looking at is the right leg. We're looking at it from behind. You can see the femur, you can see the tibia, and you can see the fibula, the little bone to the side. Now looking at the top, that little ring that you see, that's your sit bone. So once again, if you're sitting there, put your hand underneath your glutes and you can feel that bony prominence. That's what you're looking at right there. The hamstrings all will attach from this ischium. So they'll all attach from pelvic bone. The bicep femoris means two heads. It has two attachments. One of the attachments will simply be to the femur, but they will insert, okay, all of the hamstring groups insert onto the leg muscles, or leg bones, pardon me. The bicep femoris will insert onto the fibula, whereas the semimembranosus and semitendinosus will insert onto the tibia. The semimembranosus is more membrane-like. It's a flatter muscle, and that semitendinosus is going to have a longer tendon and sits on top of the semimembranosus. So bicep femoris is going to arise at the ischial tuberosity on the pelvic bone. It's going to, so then the other head of it is going to be part of the femur, and it's all going to insert onto the head of the fibula. So that's the lateral side. And so what it will do is it will flex the knee, and then I want you to think of it as extending and laterally rotating the femur. So it'll flex the knee, and it will extend and laterally rotate the femur, or the hip joint. The semitendinosus, okay, and the semimembranosus, both of them will also arise from that ischial tuberosity, the sit bones, and they are going to attach to the medial side of the tibia. They will both flex the knee. I want you to think of it flexing. Don't worry about the medial rotation. Those are subtle movements. It's going to flex the knee. Think of it flexing. And then it is going to extend the hip. So in the simplest ways, don't worry too much about these subtle medial lateral rotations. If you want to memorize that, fine. But when you hear hamstrings, you are going to think ischial tuberosities attaching into the leg bone. They flex the knee and extend the hip. It crosses two joints. It acts on two joints. So here we have some stuff in the front. Along the anterior lateral border, we have the tensor fascia lata. That is going to go into the iliotibial band. Remember, the other thing that attached to the iliotibial band was the gluteus maximus. But here we have a nice picture of our quadriceps. We have our rectus femoris. That's our major big one. That one is going to go from the anterior inferior iliac spine. So that means part of that iliac bone, it attaches to it, and it is going to go down. It's going to meet up with the vastus lateralis, medialis, and intermedius, which is not shown on this picture. They will all go together to combine to form the quadriceps tendon. And you can see in that diagram, you can see how the patella is embedded in that tendon. Once you reach that patella, beyond that is what we call your patellar ligament, and it will attach to your tibia. Because it attaches to your tibia, the quadriceps as a whole, all of them will contract to extend the knee. The rectus femoris will work along with other muscles. The rectus femoris will work with other muscles to cause flexion at the hip. Other things that we see here is the Sartorius muscle. This is called the Taylor's muscle. It goes once again from the iliac crest, and it goes down to the medial side of the knee, and it is going to do flexion, external rotation, and then flexion at the knee. So flexion of the hip, flexion at the knee, and external rotation. It'll also abduct as well. And then you're going to see the hip adductors. And they give away their name pretty easily because they have the name adductor already in there. So you have adductor brevis, adductor longus, and adductor magnus. You also have one final muscle called the gracilis, which will also work as an adductor. So the tensor fascia lata goes to starts at the anterior superior iliac spine. So think of your iliac crest. You could actually feel that at the front. It's that bony prominence that sticks out. It inserts into your iliotibial band or your IT band. It will help with flexion of the femur, abduction, as well as medial rotation. So it will help flex, abduct, and medially rotate the femur. The next four are your quadriceps muscles. The rectus femoris is just a little bit different of the four. So it is the anterior inferior iliac spine, so it arises on the pelvis. It will go to the upper border of the patella. It will cause flexion of the femur at the hip, as well as knee extension. Then you will have the other three quadricep muscles. You'll know that they're different because from the rectus femoris, because rectus femoris has a special name. The other three are all vastus. Vastus lateralis, medialis, and intermedius. Where their names come from is where they end up. So vastus medialis, that is that kind of that quadricep bulge that you see on the medial side of your leg. Vastus lateralis is the bulge on the lateral. Intermedius is underneath the rectus femoris. All of them are going to go to that quadriceps tendon and attach to the patella, and they will all extend the knee. They will all do knee extension. The medial vastus medialis will pull the knee slightly medially. Vastus lateralis will pull it slightly laterally, but they will all extend it. Okay, so there they are again. And there are the adductors. So Sartorius, that was that Taylor muscle I was talking about. It goes from that anterior superior iliac spine, which is part of your pelvic bone. It goes to the medial surface of the tibia. It's going to flex, laterally rotate, and abduct the femur, as well as flex knee. And then you're going to have your adductors. Don't worry too much about them. Know that those three adductors, we won't make you differentiate between them. Know that they're going to arise on the pubic bone and attach to the femur. They're going to arise from the pelvic bone, attached to the femur, and their jobs are all going to be to adduct the femur. The gracilis will do the same thing. It's going to go from the pubic bone. It will go lower though. This one will actually go to the tibia, and it also will adduct. And then there's a last one that I don't think you even saw in the pictures, pectineus. It's a very small little one. It starts on the pubis, goes, so pelvic bone again, and it goes to the femur. So once again, picture these attachments, know where they are, but we're not going to ask you. You're going to have to understand that it attaches to the femur. You should be able to picture where, because that will assist you in understanding exercises. But no one's going to ask you to regurgitate that it's the middle third of the medial line of the femur. No one's going to ask you that type of detail. And once again, there they are. Yes, and they don't even, yeah, pectineus, when you're looking at that picture on the right, it's that last little muscle that's not named right above adductor brevis. So then the calf muscles, so the muscles at the back, the calf muscles are going to cause plantar flexion. They'll cause you to point. This is why we exercise them doing calf raises, right? So when we do a calf raise, we're working against resistance to cause plantar flexion. So there are two muscles that we're thinking in the back. It's our gastrocnemius and our soleus. So look at the picture on the right. The gastrocnemius is a bigger muscle. It's a more powerful muscle. It can generate a lot of force. You'll notice it attaches to the femur. It comes down to a common tendon, which you might know as the Achilles tendon, but more properly called the calcaneal tendon. The soleus is underneath the gastrocnemius. It's a flat muscle. It actually looks like the fish, the sole. That's where it got its name. But it's going to arise from the tibia and go into that calcaneal or Achilles tendon. So the difference between the gastrocnemius and the soleus is that the soleus can only cause plantar flexion. I always think of it as one sole job, soleus, sole. Whereas the gastrocnemius can cause plantar flexion as well as knee flexion. On the front of the shin, so you're looking now at the picture of the left, is your tibialis anterior. That is going to run from the anterior tibia, and it's going to go down into the foot. It will, because it's on the opposite side of the body, it will do the opposite thing that the gastrocnemius and soleus will do. This one will dorsiflex the ankle. So here they are, tibialis anterior. So lateral condyles, that's the top part of the tibia, and some of the fascia between the tibia and the fibula. It'll insert onto the plantar surface of the first metatarsal, so into the foot. It will dorsiflex, and it'll also help to invert the ankle. Okay, so it'll dorsiflex and invert. The gastrocnemius and soleus, the gastrocnemius is going to attach onto the condyles of the femur, the medial and lateral condyles. That's going to become part of the calcaneal tendon or the Achilles tendon. It'll attach to the calcaneus. Your calcaneus is your heel bone. And this one will actually mainly just do plantar flexion. You think of plantar flexion when you think of gastrocnemius. Soleus is going to attach to the fibula and then the space between the tibia and the fibula. So it's attaching to the leg bones. It is going to turn into the calcaneal tendon or Achilles tendon. Through this tendon, it will attach to your calcaneus, which is your heel bone. And once again, think of this as plantar flexion. Congratulations, you have made it through the list of muscles that you need to know for exercise theory. I know that section is very overwhelming. I've taught this class many, many times. For those of you who have not been introduced to the different muscle groups and different bones and joints, there's a lot of information to take in. I implore you, don't panic. Don't worry. What you are going to do is review. When this whole section's done, turn off the video, read the textbook, read the notes that you prepared, and then listen to the audio again and listen to the video again and repeat it a few times. Practice touching the muscle as you read about it. Remember, your body is a cheat sheet, right? You have all the muscles already there. It has to be repetition. It's a new language for you. It has to be repetition. So now we're going to carry on to talk about a different way of looking at these. We talked about the muscles, but now we're going to talk about the movements and say, who are the prime movers? The prime movers are a muscle or group of muscles that are most responsible for a joint action. Okay, so flexion, extension, abduction, etc. As we go through this list, you have to assume that the movement is done against gravity or against a resistance. So if I am just standing there and I take my arm and I abduct it out to the side, we would assume for this list of exercises that I would be holding a weight in my hand as I abduct it out to the side. Yet when I go to adduct it back to my resting position, we're going to assume now that I'm using a machine. So I'd be using a pulley lever to do the adduction. Same thing when we think about elbow flexion, we're going to picture holding dumbbells and doing a bicep curl. And then when we think of elbow extension, I want you to imagine me using a pulley system or a machine to, against resistance, extend the arm. So here we go. So shoulder flexion. In shoulder flexion, your arms would be by your sides, and you would have weights in your hand, and you would take your arms out in front of you like a zombie. And the muscles that are going to perform shoulder flexion are going to be your anterior deltoid, your pectoralis major, and the long head of your biceps brachii. So shoulder extension. For this, it's easiest to picture a pulley machine. My arms would be stretched out directly in front of me. I'd be holding the bar of the pulley machine, and with all the movement coming from the shoulder, I'd pull my arms back down to my sides. I'd be extending at the shoulder. The muscles that will do this will be my posterior deltoid, my latissimus dorsi, teres major. Remember, I told you teres major always does the same thing as the lats do. And then the long head of the tricep. Shoulder abduction, abduction. This is going to be lateral raises with dumbbells. So you're standing up, you have weights in your hand, and you're taking arms directly out to the side. The major mover is your medial deltoid. Medial deltoid. Your supraspinatus, you'll recollect that's one of your rotator cuff muscles. It is going to be involved in the first few degrees of that movement. Shoulder adduction. So now I want you to picture you're at a pulley machine and your arm is straight out to the side holding the handle of the pulley, and you are going to pull against resistance to pull your arm back down towards your legs. Your arms are out to the side, you're pulling against resistance down. So shoulder adduction, and by the way, this could almost look like a chest fly, like a cable fly that people will do, except instead of aiming to the front of the body, I want you just to imagine aiming to your side. And this is your pectoralis major, your latissimus dorsi, and then remember I told you always teres major will copy the lats. Shoulder medial rotation. Remember, this is going to be your lats, your pecs. Lats and pecs will both medially rotate. The teres major will help, as will the subscapularis. Medial rotation, to remind you, is if your arms sit there with your elbows bent, with your hands in front of you. Okay, elbows bent. Medial rotation would be bringing those arms across the abdomen, across the torso. That would be a medial rotation, would occur at your shoulder. If I laterally rotate, I would just take them in the opposite direction. So my hands would be opening up, my hands going out to my side. And lateral rotation is infraspinatus and teres minor. Shoulder horizontal or transverse adduction. So this, you picture a chest fly thing. So you could be lying on your back with dumbbells in your hands, and you could be performing a chest fly. You could also be performing a pec deck. This would be your pectoralis major and your anterior deltoid. Shoulder horizontal abduction. Okay, shoulder horizontal abduction. This would be in a bent over position. So you'd be bent over. You'd have your arms originally in front of your body in the bent over position, and you'd be flying the arms out wide. So you would take the arms up and back. There are machines for this as well, where you would sit at a machine with your arms straight out in front of you, and you would pull against resistance to pull your arms wide. You'd be doing a posterior fly. This would be the posterior deltoid. Mainly think on this one, the posterior deltoid, teres major it would help with, and latissimus dorsi. Really, posterior deltoid, latissimus dorsi. These other muscles are going to just assist a little bit. Scapular elevation, so shoulder elevation. Imagine holding dumbbells in your hands, your arms directly by your side, and you are going to shrug your shoulders up. You're going to shrug them up. The muscles would be your levator scapula and your upper trapezius. Shoulder depression. Imagine you are you have your arms on, say, parallel bars. Okay, so imagine you are hanging with your arms straight on parallel bars. And if I did shoulder depression with against resistance, my lower trapezius would be doing that work, as would my pec minor. We haven't talked much about pec minor. Scapular protraction, that's the rounding of the scapula forward. A muscle called your serratus anterior does that. Scapular retraction, so I'm holding something like a pulley row cable in front of me and I squeeze my shoulder blades together in the back. That's my trapezius and my rhomboids, the middle trapezius and the rhomboids. Let's not worry too much about scapular upward rotation, but instead let's look at elbow flexion. So I have dumbbells in my hands and I'm going to do a bicep curl. It's my biceps brachii. If I'm doing elbow extension, this would be a tricep extension. So once again, imagine a pulley system and I'm grabbing onto the pulley system. My elbows are originally bent and I straighten them. That would be elbow extension. That would be my triceps. Wrist flexion, we didn't talk much about this, but if I'm standing in an anatomical position, if I flex my wrist forward, that means my hand and fingers would go anterior and forward. All you need to know is wrist flexion is done by the wrist flexors. And wrist extension is going to be taking those hands back, is moving posterior, and it would be the forearm or wrist extensors. So looking now at the lower extremity, hip flexion. So that would be pulling my knee or my hip. Okay, so sorry, let me say it again. That would be pulling my femur up against resistance. The muscles that will do this are the iliopsoas, which we call the hip flexor, the rectus femoris. Okay, so that's one of the quadriceps. It's the only one of the quadriceps that will cause this. The Sartorius. And the tensor fascia lata will also help with this. Hip extension. So once again, I'm pushing my femur back against resistance. I'm extending my hip against resistance. Think of this as you're lower down in a squat. So you're already in the squat and you're standing up. That's hip extension. Or else if you're sitting on a chair, you're standing up out of the chair. That is hip extension. And the muscles that do that are your gluteus maximus and then your hamstrings. And the three hamstring muscles are the biceps femoris, that will attach laterally, and the semitendinosus and semimembranosus, which insert medially. Hip abduction are going to be muscles that take the hip out to the side. And that's your gluteus medius and minimus. Remember I said they'll always do the same thing. And the tensor fascia lata will also do this one. Hip adduction, pardon me. This is going to be the hip adductor. So adductor longus, adductor magnus, adductor brevis, and the pectineus and the gracilis. Note that magnus is spelled incorrectly in that chart. Hip lateral rotation is going to be the gluteus maximus. Remember I said it was a skater's muscle. It will extend and laterally or externally rotate. That would be rotation at the hip that ends with the toe pointing outwards. In contrast, hip medial rotation, that is where you would rotate where the toe would point inwards. And remember I told you gluteus maximus will take you external, gluteus minimus and medius will bring you internal. Knee flexion is going to be caused by the hamstrings, which are the biceps femoris, the semitendinosus, the semimembranosus, the sartorius, that Taylor's muscle, that's that long muscle that crosses along the front. That will help with knee flexion. And the other one will be the gastrocnemius. Knee extension, knee extension, so straightening of the knee. That would be the knee extensors. That would be kicking a soccer ball. It's going to be the quadriceps. So all of the quadriceps will help cause knee extension. So the rectus femoris, vastus lateralis, vastus medialis, vastus intermedius will all extend the knee. Ankle dorsiflexion is when you're bringing the toes upwards and the top of the foot towards the shin. Only the one you need to know on this one is tibialis anterior. Tibialis anterior. Ankle plantar flexion, so the pointing of the ankle. So coming up on your tiptoes. If you were exercises in the gym, you'd be doing calf raises. This is going to be, and you just need to know your gastrocnemius and your soleus. So gastrocnemius will cross two joints. It'll cross the knee joint and help with knee flexion, and cross the ankle joint to cause plantar flexion. The soleus solely crosses the ankle joint. And then ankle inversion and eversion, don't worry too much about these ones. Just remember ankle inversion is when the sole of the foot turns inwards. Ankle eversion is when the sole of the foot turns outwards. And then the trunk. So spinal flexion is mainly the rectus abdominis, as well as it will be all of the obliques contracting together will assist with flexion, but rectus abdominis will be the strongest. Lateral flexion will be the obliques, the internal external obliques. Those obliques will also do spinal rotation. Spinal extension will be those erector spinae. So when I extend or hyperextend my spine backwards against resistance, that will be spinal extension. That's the erector spinae. And then the last one, don't worry about the deep posterior spinal group. Don't worry about that. Know that rotation is the obliques. And then finally, to compress the abdomen with no movement, that was that innermost layer, that transverse abdominis. So describe the planes of motion. So we have the sagittal plane, cuts your body into left and right halves. It's a plane of motion that allows for flexion and extension. So that could be walking, running, bicep curls, ham curls, squats, lunges, all exist in the sagittal plane. The frontal plane is going to cut the body into front and back halves. To move along the frontal plane would be abduction, adduction, and lateral flexion. And movements will be jumping jacks, lateral leg raises, lateral flexion movements. The last one is going to be the transverse plane. This is the rotational movements. The other thing that can happen in the transverse plane are horizontal adduction and abduction. So horizontal add and abduction, such as a chest fly or posterior fly, would be exercises that occur in the transverse plane. The hip is a ball and socket joint. What happens at this joint? Flexion, extension, abduction, adduction, circumduction, and rotation. And then we just talked about the movements of the spine: flexion, extension, lateral flexion, or sometimes called lateral bending, and rotation. Rectus abdominis will be flexion, erector spinae will be extension, lateral flexion or rotation will be the obliques. Review this information. Please spend lots of time reviewing. Do not be overwhelmed. Repetition will make this all make sense.